Today I'll be talking about the cisternal portion of the trigeminal nerve. In my prior lectures and the future lectures, I'll have a lot more anatomy than today. Because the cisternal portion just passes through the CSF, there's not too much anatomy to describe, and most of the talk will be about pathologic cases. Does anybody see any abnormalities on these images? Please type in your response if you have any. I guess there's no takers for these images. And I just wanted to use this format to show the problems that we have in looking at images in the clinical work. How about these images? Anybody see anything? I'm not getting any responses. Anybody watching this talk? Very good. Eric pointed out there's enhancement of the trigeminal nerve. And if you look, all these nerves are enhancing. Now, to go back to these images, this patient was studied twice, and no mention was made of the enhanced trigeminal nerves. And that's the issue that in the lecture I put the abnormality right in the center of an enlarged image so it's easy to see. But in actual clinical work, we are faced with these images, and many times we will not see unless we know where to look. So it's important not to be too critical on some of the misses, because in the busy clinical work, these very small abnormalities may not be seen. The problem with this case was that the two studies that were missed, the history said patient was tingling and numbness of cheek and upper lip. So that should have led people to look in the trigeminal region, but no mention was made of the abnormalities. Okay, the cisternal portion, it's actually the correct term is the preganglionic segment between the takeoff from the lateral aspect of the pons all the way into Meckel's cave. The cisternal portion is another term, but the issue is that the Meckel's cave is also a cistern in a way, which I'll talk about next week. So some people prefer the correct term of preganglionic segment, but we all use the cisternal segment, which is appropriate. Now, if you look at these images, it's hard to see the entire trigeminal nerve on both sides. We see all of it here, part of it here, and part of it over there. Now, I wanted to show the entire nerve, so last Thursday when I was at the VA, I found this case, but actually the regular image did not show both nerves adequately, and I had Pradeep reformatted slightly, so both of them will show up nicely here, the full cisternal course. Now, the reason for these problems relates to some obliquity, as you'll see later. So unless the patient is completely straight in the scanner, you will only catch sometimes partial imaging of the trigeminal nerve. Sometimes you will see early division of the trigeminal into the various fiber tracts going to V1, V2, and V3, as you can see in this image here, as well in this image here with a separate fiber tracts instead of a single structure. So that was on the axial. We can identify the cisternal portion of the trigeminal nerve well on the coronal plane. Here's a level of the pons. We can see on either side of the pons, we see both trigeminal nerves. You see here the corticospinal tracts coming down. And again, on this post-contrast image, we can see both trigeminal nerves. We see it on the coronal T2 and on this thin coronal at T2, again, both trigeminal nerves. Now, of course, DTI can also show us the trigeminal nerve. Here's the right trigeminal nerve showing up in green because of the anteroposterior direction. And we can even see it in the coronal plane. This is one of the images I found in among our cases. Again, the corticospinal tract in kind of bluish, purplish color. Here are the two trigeminal nerves. I'm sorry, this was in the literature, and this is one of our cases, again showing the trigeminal nerve in the coronal plane, just like in this anatomic specimen. This was an interesting case. Patient had a 2-year history of left hemiface numbness and impaired taste. And what we see here, at least on the T2, that the cisternal portion of the left trigeminal nerve is much smaller than the right. And you can see both on the axial and on the coronal plane. However, on the FLAIR image, the right looked a little smaller than the left. So, but you know, this is, I don't think, part of the nerve, but it was called also on the FLAIR as being larger. But I think the T2 was maybe a little more accurate. So we see this unusual anomaly of atrophic changes of the trigeminal nerve, either due to myelinizing or inflammatory history. Now, this is just to show the problems why we don't see the trigeminal nerve completely. See, look how off the image here. Here we see the IAC on one side, not on either side, on the opposite side. And that's why we see the entire trigeminal on the left, but only part of it on the right. Here's another image where on the same patient, slightly different level, and we now see the full nerve, but we don't see it on the opposite side. Same problem on the coronal. This looks large, much larger on the right than the left, but a different slice, we can see that the left is also the equal size. And again, notice the ISC here and not on the right side. So just some obliquity will prevent from both nerves showing up at the same time. Okay, what's a possible etiology of these abnormalities, which are frequently seen at SMILO? Anybody? Pathology, any pathology? Correct. Gino mentioned leptomeningeal disease. What's the underlying common pathology we see? Metastatic disease that Nate just mentioned is a good possibility, but this was leukemia. Very frequently with widespread leukemic changes, we will see enhancement of multiple cranial nerves, and here we see both trigeminals enhanced. Here's another patient with acute myelogenous leukemia. Again, both trigeminal nerves are enhancing, both on the axial and the coronal plane. Another case, acute lymphoblastic leukemia, again, enhancement of both trigeminal nerves. This was an unusual case from the literature. Again, acute lymphoblastic leukemia, we see the cisternal portion of the nerve enhance and expand in size, but look, the whole tract from the nucleus is also involved. So if we look at this diagram, here's the motor and sensory nuclei, here's the nerve traveling towards the root entry zone, and this whole area is involved all the way from the nucleus to the surface of the pons where the nerve exits. What is the abnormality in this case? And what condition may that be? Any other responses? Correct. As was pointed out, there's enhanced, Gino pointed out, there's enhancement in the trigeminal nerves, and as well as in the brachium pontis on the right side. As you can see, the signal and the flare and the enhancement. Any possible pathology here? Not likely MS, which was mentioned. Any other possibilities? No, not sarcoid. Correct. Stefan has gotten close to the answer. This was a chloroma, which is an extramedullary tumor in a case of acute myeloid leukemia. And of course, lymphoma is also extremely common. Here's a case with right trigeminal enhancement in a case of lymphoma. This was a case we had recently of a very unusual, rare mantle cell lymphoma, again showing both trigeminal nerves enhanced. And again, notice on this image we see the right trigeminal, but not the left. Slightly different level. The left is seen, but not the right. Okay, what is the abnormality here? What's involved? Anybody? Correct. Gino mentioned the involvement in the region of the nucleus. So the pons is involved. What else is involved? Correct. There's marked enlargement of the right trigeminal nerve in the cisternal portion. Notice it gets small when it goes to Meckel's cave. What is this condition? Involving a large portion of the pons and the trigeminal nerve. Unlikely to be a schwannoma. A schwannoma is unlikely to enlarge the nerve and the pons to that degree, although it's an interesting possibility. Correct. Asif mentioned the correct diagnosis here. This was lymphoma, extensive lymphoma involving the pons and spreading into the trigeminal nerve. Okay, here we have a patient showing enhancement of both trigeminal nerves, a little more on the left than the right. History, 11-year-old with history of recent camping. What's the diagnosis? Correct. Eric and Anshu both came up with the correct answer. This is Lyme disease, okay? Which we see not infrequently in this part of the country. What's the abnormality in this case? These are thin T2s, axial. Correct. As Nate said, the left trigeminal nerve is enlarged compared to the right. And again, marked enhancement, a little bit of enhancement on the right, significant enhancement on the left. Again, a case of Lyme. This was an interesting case. This was a 70-year-old female, had very positive Lyme titers, but also had clinical signs of a Guillain-Barré. And you can see, not only do we see the enhancement of the trigeminal nerves on the coronal and axial plane, but there's enhancement of the cauda equina here on the sagittal view, and look at the axial post-contrast spine. You see all the marked enhancement of the cauda equina, somewhat of an unusual symptom of Lyme disease. Okay, here's a patient who presents with bilateral facial palsies. What are the findings here? Correct. Both Eric and Nate point out the marked enhancement of the trigeminal nerve. However, why would the trigeminal nerve give facial palsy? It gives facial numbness, not palsies. So what other finding is there on these images? Correct. Both Eric and Gino picked up the other abnormality in the IAC. So here we have the trigeminal. This patient had Lyme, but the facial palsy was not due to the involvement of the trigeminal nerve, but the facial nerve. You might see here both facial nerves in the upper part of the internal auditory canal show enhancement, and that was the cause of the facial palsy and not the involvement of the trigeminal nerves. Sometimes you'll see enhancement of the trigeminal with viral meningitis, as in this case. Again, noted the right, both the right and the left are involved in the axial and coronal plane. This patient presents with pain in the V2 distribution of the trigeminal nerve. Possible etiology? Anybody? So far I've had several answers, but not the correct one. What's the correct answer? I have not seen the correct answer yet. Please look at all the images. What about the brain image? Looks slightly characteristic? Correct. Asif has mentioned the correct diagnosis. This was a case that nobody thought about MS in this case, but the appearance of the brain suggested that, and eventually this case was proven to have MS. Again, notice the involvement in the region of the root entry zone, which, remember last week I mentioned is kind of a favorite place for MS disease. This case was brought to my attention by Ash at the VA. And I guess MS is so unusual that this was also published as a case showing the involvement of the root entry zone and part of the cisternal portion, and here are the brain lesions. Okay, what is the abnormality causing the enhancement of both the trigeminal nerves in this case? A condition we have not discussed as yet. Correct. Our chief, hail to the chief, as somebody said in the chat, is correct. This is a case of sarcoidosis. And here's another case showing involvement of the trigeminal nerves by sarcoidosis. Now, this case gave us a lot of headaches for a while to try to come up with diagnosis. Any suggestions here? Correct. Everybody, several people, Asif and some, let me see who else mentioned that. Let me go. And Eric also mentioned sarcoid. And this was a diagnosis that our department came up with for a while. And actually, this case was listed in my collection as a sarcoid. And yesterday evening, I said I better check this out. So I went on Epic, and I was shocked to find out that this was not sarcoid, although that diagnosis is what we talked about in the section for a while, and I think most people thought it was sarcoid. And actually, the pathology came back initially as sarcoid, but this was not sarcoid. Any other possibilities? No, it was not TB. It was not an infectious situation. And it was not a meningioma, although Stefan mentions meningioma, which is not a bad possibility, but it was not meningioma either. It's a very unusual, rare condition. This was idiopathic hypertrophic pachymeningitis, right in the EPIC chart, as listed IHP. This is extremely rare. The origin is unknown. There may be localized or diffuse fibrosing, inflammatory, and thickening of the dura. And it's also been described associated with rheumatoid arthritis, Wegener's, TB, and cancer. And this patient unfortunately presented with a large number of cranial nerve abnormalities and other symptoms. And I just selected a few of the images. You can see again this involvement of the dura and the tentorium, involvement of the IAC. The patient had 7th and 8th nerve symptoms. Look, there was tremendous thickening in both orbits. The patient had some visual problems. Here at the foramen magnum, the marked thickening of the dura, and again in the region of the jugular foramen. So this was a very unfortunate condition causing multiple cranial nerve abnormalities. Okay, what do we see here? Correct. As Eric pointed out, we see enhancement of the trigeminal on the left side. We see, as I discussed last week, we see involvement of the trigeminal spinal tract, involvement in the region of the medulla, high medulla, lower medulla. And what's the condition causing that, as I showed last time? Correct. As Eric pointed again up, this is herpes. Okay, so herpes involving the cisternal portion of the nerve as well as the trigeminal spinal tract going down to the medulla. Why am I showing this case? I'm showing this case because of the trigeminal nerve. But what is the condition in this case? Correct. Stefan, Eric, both mentioned siderosis. This was post-op for GBM, and notice extensive siderosis involving you see all the sulci here, multiple cranial nerves, and in this case, markedly thickened left trigeminal. Now, this is a condition that nobody will ever come up with the correct diagnosis, so I won't belabor this, but this was a case of neuroschistosomiasis and showing marked enlargement and enhancement of the both trigeminal nerves. And again, this case that I showed last week of listeriosis, again showing all the findings I pointed out last week along the track and going all the way down to the medulla along the descending spinal trigeminal tract. And again, just to point out the enhancement of the cisternal portion of the trigeminal nerve, in addition to all the other enhancements. So listeriosis, an important condition not to forget about. Now, sometimes you will see enhancement of the trigeminal in metastatic disease, as Nate mentioned early on in this talk. This was a breast CA. That was the only really finding was the involvement of the left trigeminal. There were no other brain lesions that we could see. What are these markedly enlarged trigeminal? What's the etiology here, which has not been mentioned so far today? Correct. It's metastatic disease. It was not a schwannoma. What disease? No, none of the conditions so far. Not breast, not lung. Very good. Our chief again hit the nail on the head. This was melanoma, meningeal carcinomatosis secondary to metastatic melanoma. Again, a disease we have to think about in our wide differential. Now, here was a very unfortunate case. We did a study, and it looks like the left trigeminal looks like it's a little thickened and maybe enhancing a little bit. However, it was not the trigeminal which was involved. There was a lesion next to it, and if we look, there's these masses in both cerebellopontine angle, almost invading the eye. You see, maybe on the right, a little bit invading. So we were seeing like the top of the dome of this lesion projecting next to trigeminal, and that's we saw here. So this was not involving trigeminal itself. It was just next to it, maybe encasing or around it. This was the patient's initial study. What is the abnormality here? Now, it's called a pineal mass. I would modify this description, better to say a pineal region mass. Okay, so here we are. These two studies are 2 months follow-up. What's the diagnosis now? Patient was treated, and that's how it looks 2 months later. None of the diagnoses so far mentioned. What lesion melts away quickly after treatment? Correct. Richard mentioned the correct diagnosis. This was a germinoma. So within 2 months, it was gone in the pineal, from the pineal region. However, 8 months later, these masses showed up, and 14 months later, even that the pineal region looked normal, there was now involvement of the sulci and the occipital lobe, and unfortunately, this is how the spine looked. So a very sad case of a germinoma that in the original area looked like it disappeared, but was widespread disease all over the place. Now, this was a case sent to me showing enhancement of the trigeminal nerve by a former fellow, Joseph. This was a massive and large GBM of the frontal lobe, and actually spread to involve the trigeminal nerves. And that's why he sent it to me. What is this case? Another patient was sent to me by a former fellow, David. Anybody see the abnormality here? Correct. As Eric said, a mass or a suggestion of a mass at the left cerebellopontine angle. Any other structure look abnormal in this case? Correct. Matthew and Stefan mentioned, besides this region, that the left trigeminal cisternal portion is prominent here. Patient presented with left facial numbness because of involvement trigeminal. What's the diagnosis here? Not mentioned before, somewhat of a wild case. Could be multiple cavernomas, but it was not the case in this patient. Was not Sarcoidosis, another interesting good possibility. What if I told you it was a man? these they wouldn't have sent me. Very good. Matthew came up with the right answer. This was prostate. Patient had a very high PSA titer. He also had bladder cancer, but because of the very high PSA titer, these were prostatic mets. You know, most of the time we see metastatic disease involving the dura or the meninges just below the dura, but this is an unusual case for that for that disease. Okay, what are we seeing here? Very good. Both Eric and Nate, which side is abnormal? You did not say yet. Right or left? Correct. Notice here's the right trigeminal. This left trigeminal looks kind of very atrophic. Then we have this is not CSF. What is this peculiar density? I presume you want more images, which I'm happy to oblige. So here's a T2. There's a structure within the prepontine cistern encasing the left trigeminal nerve. And here's the clincher, the diffusion imaging, and the ADC, the high restriction on the diffusion, and again on the ADC. And this was an epidermoid, an extensive epidermoid encasing the trigeminal nerve and causing its atrophy. The problem with these lesions is that surgically they're very difficult to remove because of the nerves that course through them, like in this case the trigeminal. Patient presents with right trigeminal symptoms. May I have some diagnoses? No diagnoses at all? Okay, one possibility mentioned is a schwannoma with degeneration. Several people mentioned that possibility. Was mentioned also cystic meningioma. All are interesting possibilities. My philosophy in skull-based lesions is always do 2 studies. If you see a lesion on MR, maybe CT will help. If you see a CT lesion, definitely do an MR if you're not sure what's going on. I presume everybody's eager to see the CT. Okay, what is happening now as far as the differential that was mentioned so far? Very good. Everybody, Gino, Nate, and Eric. Oh, wait, I don't know. Mention possibilities, but I have to say that Gino came up with the right answer. This was a very destructive lesion arising from the temple bone. This was a cholesterol granuloma. Interesting, when I looked at EPIC last night to confirm that this was the case, it's listed as cholesterine, not as cholesterol. which I guess is another term that people use. It was not listed as a cholesterol granuloma, but cholesterine granuloma. So again, the importance of doing both CT and MR and skull-based lesion. And I'll show during my talks many cases where that's important. By the way, notice that we can see the trigeminal nerve pushed above this lesion, again, which would be unlikely for a trigeminal lesion to do that. That it had to be extrinsic to the trigeminal, both on the pre-contrast, on the flare. Notice here the trigeminal pushed above the lesion. Patient presents with left face numbness. Any diagnoses? Very good. Eric mentioned that possibility. I'm waiting for some other answers, but I guess we'll go. Eric mentions the cystic schwannoma. And here's a thin T2, normal, markedly enlarged. We don't see the trigeminal nerve. Here it is on the coronal. Again, notice the normal and abnormal. And notice this kind of a cystic type enhancement with a non-enhancing center. And this was operated on, and this was a trigeminal schwannoma. This was a very unusual case. I could not get, I remember this case in the past, but there's nothing listed now in EPIC. But this is, again, a tiny, look at the abnormal signal in the flare. On the T2, has a cystic center, and also on the T1, we see it has like a cystic. This was a cystic schwannoma, tiny cystic schwannoma. I don't know if it was operated or not, but that's the diagnosis the patient was carrying. Okay, what is this condition? Very good. Gino and Asif came up with the right answer here. Multiple lesions involving meningioma, IACs, and trigeminal nerve on the sagittal plane that I'll show. Here it is again on the coronal. This was a 21-year-old was male with NF2. This just to show the trigeminal. Another patient, diagnosis, abnormalities of both trigeminal nerves. Anybody? Correct. As Eric says, same condition. This was, again, notice the marked enhancement of the trigeminal nerves. This was another case of a patient with NF2. Okay, patient comes in with incoordination, imbalance, and right facial numbness. Diagnosis. Correct. Asif and Eric both mentioned that correct diagnosis. this was a cystic schwannoma. Again, trigeminal schwannoma. Again, this patient was operated, and again, we can see here's the lesion. You can see the trigeminal nerve actually kind of displaced. It's a little unusual that we still see it as clearly here. And you know, you would expect with this kind of a lesion that you wouldn't identify. I don't know if maybe that's not the trigeminal or just a part of the capsule, but it looks somewhat like the trigeminal in this projection. A 15-year-old girl with 2 months of left face loss of sensation. Diagnosis: okay, schwannoma was mentioned. Arachnoid cyst was mentioned. Anything else? It was neither a schwannoma or an arachnoid cyst. Here's a post-contrast involving both the cisternal portion and Meckel's cave. It was not a neuroenteric cyst either. Any other common condition? Which actually somebody early on mentioned. It was not a glioma. What is left? A common brain tumor. Correct. Eric finally mentioned the magic word. This was a cystic trigeminal meningioma. You know, we don't expect meningiomas to look exactly like that. You know, you can see, and I'll show when I talk about meningiomas, that you can get quite large cysts, but this was an unusual lesion because it was so specific to the trigeminal nerve. So this was a meningioma. And here's another more classic case of a very small trigeminal nerve meningioma. Again, you know, the differential would be schwannoma or trigeminal meningioma. And this is the last case I'm showing. Where's the abnormality here? Correct, as Eric says, the left cerebellopontine angle, we see a mass. Post-contrast on the CT. Any diagnoses? This patient was not operated on, but I think we can at least surmise what this may be. Correct. As Asif said, we read this case out as meningioma. Again, notice the marked enlargement here. Is it just pushing the trigeminal away? But it is going towards Meckel's cave, and we see the spread along the dura, which would be very unusual for a schwannoma. So we read this case out as a likely trigeminal or trigeminal region meningioma, and this has really changed very minimally over several years. So that is the going diagnosis. So this is my last case for the day.